All right, we're going to talk about Chapter 29, the Hematologic System Introduction. This usually means we have a lot of tables to look at, so I'll be guiding you to those tables and what's important to know. So it's also interesting because we've talked about a lot of these things that are in this chapter, but we're going to find out more interesting information about each thing. And also in the next chapter, chapter 30, I'm going to talk about today. Also, we're going to learn about some disorders of the hematologic system. So let's get started. Very interesting lecture. So some structures and components of the hematologic system, we have the bone marrow, and that's where red blood cells and platelets are made. Our kidneys manufacture hematopoietin, which stimulates the production of the red blood cells in the bone marrow. Our liver, it does so many things, but a couple of things it does is manufactures clotting factors and also clears out old damaged red blood cells from circulation. Now, if you remember with the liver, those liver patients have clotting problems. They have bleeding issues. Now that's because it manufactures clotting factors. And if it's not working right, it's not clotting right. It also helps clear old and damaged red blood cells from circulation. Again, not working right. Those old damaged red blood cells look like jaundice. So that is jaundice. The spleen removes old red blood cells from the circulation. Blood carries oxygen from the lungs to the tissues and maintains that homeostasis that our body is so great at trying to maintain. Our red blood cells, or erythrocytes, carry oxygen to the tissues and carbon dioxide from the tissues back to the lungs. Platelets or thrombocytes activate our blood clotting system. Clotting factors form a stable fibrin matrix, and then our plasma carries our red blood cells, platelets, and clotting factors. Now here's just a picture. You have it in your book, figure 29.1. The body, total body weight with our whole blood that has a 55% plasma and 45% formed elements. Now, do you remember how much blood we have in our body? How many liters of blood? 4 to 6 liters. That's right. So this is the components in our blood. All right. Our red blood cells, they transport oxygen from the lungs, carrying carbon dioxide from the tissues back to the lungs. They last about 120 days, and then they're filtered out by the liver and spleen. Red blood cells also have antigens A and B, and that helps determine your blood type. You can be AB, or O. Now, Rh is another type of antigen, and that can be either negative or positive. O-negative blood is the universal donor. AB positive is the universal recipient. So, know your blood type, because you can save a life one day. Now, platelets, thrombocytes, and clotting factors, they're produced by the bone marrow. They activate the blood clotting system and form a platelet plug. The normal lifespan is 10 days. I'll refer to figure 29.2 shortly here. Clotting factors are numbered 1 through 13 and include fibrinogen, and this forms a stable fibrin matrix over a wound. So here's a picture, and it is on your page 530. It's the formation of a blood clot. So first we have vasoconstriction. We have an injury, causes vasoconstriction. The platelets release platelet factors. Then the platelets attract more platelets, so you can see them starting to congregate. They also have prothrombin activator is formed. That thromboplastin initiates prothrombin. Prothrombin initiates thrombin. say this 10 times. Thrombin to fibrinogen and fibrinogen to fibrin. Fibrin is what causes that matrix or the threads that look kind of like spaghetti, but those are forming a web so that we don't bleed anymore. And so it's a healing, helps us start to heal. So this is the beginning of a blood clot and healing. And notice it heals from the bottom up. It doesn't just form a sealant on the top, but it begins to heal from the bottom up. Then we have the plasma. It's a clear straw-colored fluid that carries the red blood cells, platelets, and clotting factors through the circulation. It's mostly water, but when it is made up is plasma, albumin, so important, it's our protein, and globulins. So, some functions of the hematologic system we've kind of talked about already. Oxygenation, repetition, very important. Oxygenation, homeostasis, controlling of bleeding. Our blood vessels constrict. Our platelets form a plug. The coagulation cascade forms a matrix, and that begins the process of clotting. So again, I'll refer you to figure 29.2. Some nursing assessment of the hematologic system. So you want to check out their history. Why are they there? What brought them to your facility? What's their present health? You want to do a review of systems. You want to check out their past health history. Any underlying problems that they have, or any medications that they're currently on that may tell you why they have a bleeding disorder. Their family history. Do they have a history of blood disorders? And you want to do a review of systems, their integumentary or skin, respiratory system, cardiovascular, GI, musculoskeletal, neurovascular. Their functional assessment is really important here because we want to know what was their job, what was their hobby. Maybe their job was some toxic chemical exposure, or their hobbies have that glue that can release a toxic odor, and that can cause some disorders of clotting. Do a physical exam. Note their general state of health. When you take their blood pressure, do they have any orthostatic changes? If they do, you may realize they've got volume depletion, maybe secondary to bleeding. Let's look at their skin, the color. Is it pink? Is it pale? Is it jaundiced? Did you notice any bruising? If you did notice bruising, you might ask them, how did you get this bruise? And they'll say, I don't even remember getting it. Well, maybe they didn't hit anything. Maybe they are getting bruising because they have a clotting disorder. And then petechiae, those little red dots under the skin. So those can be caused from bleeding disorders. Look at their head and neck. Is there cracking at the corners of their mouth? Look inside and their tongue. We're going to be talking about some disorders that might cause you to pause when you look at these areas. Also, notice their chest, their respiratory rate. Are they tachypnic? They might be because they're trying to get more oxygen in, breathing faster because they don't have any hemoglobin carrying oxygen to their organs. So they're breathing faster, so they're trying to get oxygen in so that their organs are not deprived. So take note of that. Check their abdomen. You might notice some spleen or liver enlargement when you palpate, or maybe their abdomen is just generally enlarged. Some diagnostic tests and procedures. So let's turn to table 29.1 and look at some of these lab tests. So our red blood cell count, notice adult is 4.7 to 6.1. and a female is 4.2 to 5.4. Hemoglobin for an adult is 14 to 18, and a female is 12 to 16. Now, let's look at the hematocrit. Adult male is 42% to 52%, female 37%, 47%. What do you notice? Well, you notice that, important, the hematocrit is 3 times the hemoglobin level. So just look, 3 times 14, what is it? 42. So you've got to have that value, 3 times the hemoglobin value. What does the red blood cell mean? Well, it's not getting enough oxygen. There's that MCV. This is a CBC with differential, is going to give you some of these indices. Then their white blood count. What is that? And that is also a differential. Normal white blood cell count is 5,000 to 10,000. We know that's usually indicative of an infection. Their pro-time, the normal is 11 to 12.5. That might be altered in different diseases or medication that's given. Their activated PTT or APTT is 30 to 40 seconds. It should not exceed 70 seconds. If you have a prolonged APTT, it could mean hemophilia, biliary obstruction, liver disease, heparin, or some other drugs like salicylates. And then let's notice the PTT, which is 60 to 70. If they're on anticoagulant therapy, it's usually 1.5 to 2.5 times that. So if they're on Coumadin, it would be 1.5 to 2 times that, or heparin. Their platelet count, normal platelet counts, 150,000 to 400,000. So take note, is it low or is it high? And notice low bone marrow failure, hemorrhage, platelet destruction by drugs, high estrogens, oral contraceptives, or even high altitude. So let's look at the bone marrow biopsy on 29.2 also. I want to go over that. So a bone marrow biopsy is used to evaluate how well the bone marrow is measuring white blood cells, red blood cells, and platelets. The most common site for a bone marrow is the iliac spine. Now, they have done them in the sternum before. It's very painful. So that's not a good place. You know, that's not much skin there. So the iliac crest, the patient should lie prone on their abdomen, and they will get a numbing agent into the area of the iliac spine where the physician's going to go in. And he will inject a needle into that area and aspirate some bone marrow fluid. It's called a core biopsy. The needle's removed, a pressure dressing is applied to the site, and that biopsy will be sent right away to the lab. Now, it's up to you to keep an eye on that patient after a biopsy. So you want to be careful and watch the puncture site for bleeding. That would be abnormal. So check the puncture site for bleeding. The dressing, it can be removed after 2 hours. Bed rest may be ordered for 30 to 60 minutes, and they might be pretty uncomfortable. So this is just a picture of the needle going into the iliac crest and taking a biopsy of some bone marrow. You have that in your book. All right, some common therapeutic measures. Nursing actions for the patient at risk for injury from low red blood cell counts. Refer you again to box 29.4, and that's some blood transfusion reactions don't think that's where I wanted to take you, though. I wanted to take you, oh, I see, 29.5. I'm sorry, it's box 29.5. It's confusing because there's boxes and tables. So I'm sorry, box 29.5. Nursing actions for the patients at risk for injury from bleeding. Administer blood product transfusions as prescribed. Minimize the number of invasive procedures done to the patient. Draw blood for as much lab work as possible with one venipuncture, not multiple. Avoid prolonged tourniquet use. Apply pressure for 5 to 10 minutes because the clotting isn't as good as it should be. Avoid IM injections. Avoid damage to the rectal mucosa that might cause damage by taking the following measures. Avoid taking rectal temps. Avoid suppositories. Avoid enemas. When measuring the blood pressure, inflate the cuff only long enough to get your blood pressure because it can cause bruising, petechiae. When measuring the blood pressure, also have them use, let's go to number 5. Instruct the patient to use a soft bristled toothbrush so they don't injure their gums or have bleeding gums. They might already have bleeding gums. We don't want to cause more injury. Instruct the patient to use an electric razor, not a regular razor. As much as possible and prescribed by the physician, avoid the use of drugs that interfere with platelet function. Aspirin, aspirin-containing drugs, Pepto-Bismol, Percodan, and NSAIDs. And then also be sure you teach the patient. All right, nursing actions for the patient at risk for injury from bleeding. Now let's go to blood product transfusions, the A, AB, B, and O. There's also an autologous blood transfusion where you give your own blood. Autologous always means you're giving it to yourself. Well, it is your own blood. You're not giving it to yourself, but it's your own blood that you've given to the blood bank to give back to you. That's when you know ahead of time you're going to have a surgery or you might need a blood transfusion, and you can have that taken ahead of time. Now, colony-stimulating factors are naturally occurring hormones that stimulate the bone marrow. Erythropoietin may be given for symptoms of anemia for patients on dialysis or that have HIV or cancer. So let's turn to table 29.5 and let's look at some medication. So we've got that erythropoietin that I was talking about. You can look along there, but I want to call your attention to oral iron preparations. And that's like ferrous sulfate. Here they mentioned Fiasol. Ferrous sulfate is another type of oral iron. So that we would give with food initially, then transition to between meals. Give with food only if GI effects are tolerable. If they have to take liquid iron, that should be diluted and administered through a straw. Important to remember because that iron can stain their teeth. So it should be diluted and administered through a straw. The other thing I want you to notice is the parenteral iron. So that can be given IM using the Z-track method. I think you remember doing that in Skills Lab where you kind of make the skin into an S and inject deep IM injection, then let go, so that the infusion is absorbed in a zigzag pattern. It's not absorbed all in one spot. So just be sure you notice that, take note and remember the oral and IM iron. All right, let's talk about transfusion of red blood cells, box 25.6. So let's all turn to that. 25.6, and I do believe it's 29.6, isn't it? Yes, it is. All right, first we have to have a signed consent for blood transfusion, an 18 or 20 gauge needle. Any smaller size can damage the blood cells. Now, blood is always transfused with normal saline. So start an IV of normal saline, and then you can piggyback the blood into the normal saline. When you receive the blood from the lab, 2 licensed people should check the blood at the bedside. Make sure it's the right patient. Check the name and the date of expiration. We don't want expired blood given. Blood should be started 30 minutes within receiving the blood. Now, if your physician ordered 2 units of packed RBCs to be given, and they send up 2 units, you don't infuse 2 units at the same time. You can only infuse 1 unit at a time, and that's over 2 to 4 hours. Well, send that other blood back to the lab. You can get it back when you need it after the patient has received the first unit over the 2 to 4 hours. And that amount of blood is usually about 250 to 300 mLs. You can check on the bag how much is in there, and that would be included in your intake when you do I&O. So record the patient's vital signs prior to giving the blood, and then stay with the patient for 5 to 10 minutes. You might take their temperature again. There'll be an order from the physician. He'll say to take vital signs maybe for every 10 minutes for 3 times or for 30 minutes. And just to keep an eye that they're not having a transfusion reaction. And that could be manifested by a fever, chills, a decrease in the blood pressure, or even back pain. So stay with the patient initially when they get a blood transfusion. So platelet transfusion, now that's different, isn't it? 29.7. So by the way, that blood transfusion is on 29.4. That lists some of the reactions that can occur. So let's go to 29.7, if I can find it. There it is, administration of a platelet transfusion. So when a patient platelet level falls below 20,000 cells per mm, they will require some blood transfusion. For each multi-donor pack, so it takes several people to make 1 unit of platelets. So they're very precious. The platelets could increase by 5,000 to 10,000 cells per mm. They need assigned consent. Platelets are smaller than red blood cells, so they can be given in a smaller needle, 24 gauge. Again, though, 2 licensed people need to check the name on the platelets and the date of the platelets. Be sure they're not expired at the patient bedside. Monitor the patient vital signs, so record prior to giving the platelets and then also during the transfusion, and watch for any reaction. Platelets can be infused rapidly, unlike blood, just as fast as they can tolerate. It's commonly ordered as a 4 to 6 pack, so the doctor will order 4 units of platelets. Just run one at a time, though. So again, you can read the administration of platelets transfusion. Now, fresh frozen plasma, or FFP, that contains clotting factors and plasma proteins. It's separated from whole blood, so it's a smaller, even volume. Cryoprecipitate, which contains only fibrinogen and factor 13, can be further separated out from plasma. So let's try a question. So after about how many days the old red blood cells are filtered out of circulation by the liver and spleen. So I'll give you a minute. So if you guessed 120, you're right. It's D, 120 days. Question number 2. A person with type O blood would have what kind of antigen? Give you a minute. O has neither A nor B. It will be positive or negative, but it has no A or B antigen. It's just O antigen.